Welcome and good afternoon. This is one of our continuing research presentations from the Center for Business Analytics that today is also co-sponsored by the College of Nursing. My name is Matt Liberatore. I serve as the director of the Center for Business Analytics. And we're very pleased today to have Dr. Katrina Adams from Lpa Solutions to speak to us about predictive analytics for Parkinson's disease to identify risk factors to drive patient care. Dr. Adams is a co-founder of Lpa Solutions and serves as both Vice President of Operations and the Predictive Analytics Lead. Previously, Katrina held positions in both project and development management in the UK and across the United States, as well as in Belfast, Northern Ireland. She graduated from Queen's University in Belfast with a Bachelor of Science degree in Applied Mathematics and Statistics and a PhD in Applied Mathematics. Please give a warm welcome to Dr. Katrina Adams.
Thank you, Matt. Okay, make sure all systems are go up above at the video end. I think so. Can you all hear me okay? So you now know I have an accent. I went to Queen's University in Belfast a long time ago. A proud alum of that grand school. And I have come with a background in mathematics. So before we get into this particular presentation, which really is a lovely combination of clinical topics and data analytics and mathematics for those of us who really want to get down into the details, I'd like to get a feel for my audience. So representing the nursing school, could you raise your hands? Excellent. And so how about the business school? Oh, nursing school, they have you outdone. How about any engineers? Shameful, shameful. And anybody, any arts school? Excellent, look at that. Whoa. All right, well, I think there's something in this presentation for all of you. But first of all, this is a human story, thinking about Parkinson's disease. Show of hands of who have been touched by somebody in their lives who's had Parkinson's disease or has it. Anybody? So a lot of you know what this is all about. And we at LPA were very fortunate to work with our friends at the University of Rochester Medical Center to do some investigations and analysis around this topic. So today what I'm going to do, we've done all the introductions. We'll come through some of that topic a little bit further about our colleagues at the medical center. I'm going to give you some background on Parkinson's disease. We've got a good mix. This is nice to have the cultures coming together here. Talk to you about the data sets that they have at the medical center. They have a large volume of data that's not been untapped. So there's information in there that we could all get our hands on that would be, I think, help everybody. Talk to you a little bit, very little bit about the technology that we use to do our analysis, the project approach, the results that we got to date. So this was a proof of concept type exercise, and then what our next steps are, which was to apply for a grant. So I'll give you the results of that application when we get to the end. So this analytic exercise around the Parkinson's data was a collaborative effort between the University of Rochester Medical Center. They brought together not only themselves, but also the data. They have clinical trial data. We'll talk in detail about what they have that I think really started and got the seed of the thought process going. Our IBM colleagues, I think we have our IBM representative here in the room, and we used their software as well as their expertise in working in healthcare data. It was a wonderfully powerful collaborative team, and ourselves from LPA, and our strength is we know data and we are strong in the predictive analytic analysis techniques. So it was a great team. The particular group within the University of Rochester Medical Center is the Center for Human Experimental Therapeutics. Easier to say if you say CHET. And they have a mission to conduct hypothesis-driven and they have a rigorous process to investigate novel therapeutic interventions for human diseases. It's a long, big mouthful. But they do a lot of work with the drug companies, as you can imagine. And some of these data studies, actually the data belongs to some drug companies. So the university has the right to look at the data and use it. They don't have the right to do anything more than that with it. But everybody's cool with that, I think. My colleague, Don Pongi, who's a VP of Business Development, is going to tell you a little bit about us. So, Don?
So I'll be very brief. This is the commercial on who LPA is. And I'm happy to say we're here today doing this at the invitation of Dr. Liberatore and the Center for Business Analytics, which LPA is a member of, and we're excited. And I need to call out Mike in the audience here, who's a senior business student and happens to be a roommate of my son, who's a senior chemical engineer here. And we got talking last spring, and he said, you guys should really, you're in this data analytics space. You know, we got this great analytics stuff going on in the business school. So through those connections, here we are. Lpa Software Solutions is a company headquartered in Rochester, New York. We have over 50 people now. We were only 30 in January. We're over 50 now. Most of that additional 20 have been folks about a year or two older than all of you. Because of the booming nature, so to speak, of analytics consulting and the use of big data and analytics by all sorts of companies, not just healthcare, but just about any industry, we're seeing explosive growth in the need for our consulting. And we're primarily a consulting company. We also, resell IBM software because that's where our expertise happens to be. But as the charts say, if you look at the bottom, most of our consultants have experience of over 10 years, 10 plus years, except for the new group of young students that we just recently brought in who are been going through a boot camp and training over the past 2 or 3 months and are now starting to get deployed on real projects, throughout the business. Done with the commercial, back to Katrina, the main star.
Okay. So let's get into the business of the trials and tribulations of Parkinson's disease drug development. So Parkinson's disease is a very complicated disease, very difficult to diagnose, and no two patients are the same. You walk in and you're going to be diagnosed. The doctor has very little information to give to you to help you understand what that diagnosis really means. Am I going to be here for 2 years, 20 years? Doctor, what's the answer? Patient, I don't know. And part of this study is to try to get to the bottom of that. What is the rate of progression of this disease, to understand that? This slide talks about all the failures that they've had. There are, even in the drug development side of things, this is still fresh ground. So all of you young students who want to make a difference in the world, this could be a place to be. So what is Parkinson's disease? It's a progressive neurological disorder. So here am I, the non-medical person in the room. But in the part of your brain where the substantia nigra is, what happens is you end up with a loss of the dopaminergic neurons. They die off. And that is what causes the motor issues that you associate with Parkinson's disease. Michael J. Fox is probably and Cassius Clay are the two that you might think of. But there's a tremor, a rigidity. Movement is a problem. Over time, speech, maybe you're writing, all of these things, anything to do with your motor system starts to degrade. Eventually, swallowing may become an issue, and dementia. So it's can be a slow decline. The question is, how slow? For one person, the slope of the graph, that speed or that decline could be very gentle, and it's a very long process. But for somebody else, it can go very rapidly. Who knows? There are 1 million people in the United States with Parkinson's disease, and there's a map here to show you more. That's expected to double by 2030. Last thing here talks about there's no therapies to cure the disease. There are the therapies to treat the symptoms and to help manage the disease, but there's nothing to cure it at this point in time. So if we look at the map here, look at the projected growth rates across the world. And you can see that the red here, for example, is greater than 100% growth. This is a disease that's increasing over time. I don't know enough from a research perspective to tell you that I know why that is. I'm sure if my colleagues from the university were here, they'd be able to give you some insight to that. But suffice it to say, this is a hot area for research. Sorry. So
that growth rate was as of 2030?
Yes.
From whatever, 07 or something?
Yes, 2005. So our colleagues, I'm going to show you, let you listen to Dr. Keepers. Dr. Keepers was the chief neurologist that we worked with at the University of Rochester. And what I want you to do is to listen to what he has to say about Parkinson's disease. Hopefully we can hear this.
Over time, people who have Parkinson's disease or other what we call neurodegenerative diseases are losing brain cells, neurons to begin with, and then afterwards, part of the repair mechanism that's trying to support those injured neurons, that starts to fail, so that eventually people get worse. They not only get worse regarding their motor function, but they can get worse regarding their thinking, their mood, their control of their autonomic nervous system that controls blood pressure and urinary bladder and other things. So the disease becomes more complicated, more multifaceted, more severe. So yes, in the early stages of the disease, we have therapies which are potent and reverse the motor signs and symptoms. But yes, also in the long run, things get worse. So we're very interested in therapies that not only treat those initial symptoms, but might slow down, maybe even stop. Perhaps the Holy Grail is something that even reverses that loss of nerve cells. And the types of drugs that do those two things are likely different.
Okay, so we worked very closely. He was part of this collaborative team. You can imagine for a young mathematician dealing with a neurologist, we had to get to a common language together. Never mind the accent. Okay, so we need to make sure we can actually move here. So just to give you a little bit more about the diagnostic accuracy. So starting out, you can see for our untreated patients, it's even being able to tell somebody that they have Parkinson's is a bit of a challenge. And as they go through the progression, they can get more accurate over time. In the last group there at the bottom, so now they've been treating as a patient, as a PD patient, and they've been responsive to treatment. They pretty much know 85% of the time what they're dealing with. But starting out, that first conversation, patient, you have Parkinson's disease, is a pretty blunt conversation because there's no more detail to provide. And we all, as patients in our lives, if you haven't been one, you will be one someday, I'm sure, will want to know, well, doctor, what does that mean? So as I talked to you, Michael J. Fox and Cassius Clays, it's the picture here, but spectrum of these clinical manifestations, that tremor, that akinetic rigidness of your movement, and even all the way to these non-motor items. Dr. Keepers mentioned your mental state. Depression is a big part of the disease, as you can imagine, and part of managing that over time. Oops, I'm having a problem with this keyboard. So CHET, the University of Rochester Medical Center group that we worked with, there are large clinical trials. They have large, huge data sets, not only a large number of patients, but longitudinal studies, so over time. So being able to look and monitor the progress of these patients over time and how their disease state changes. Of course, these studies are all expensive. Drug research, developing a new drug is very expensive, and he's referenced one here that this clinical trial cost $20 million. So part of the reasons maybe why drugs are so expensive. CHET, their study experiences, I'll not read through all of that, but they have a large clinical trial group they work with, Dr. Keeberts, Dr. Dorsey, and Dr. Venuto with the team that we worked with, and they have been working in conjunction with various drug companies, and you can see the names of those drugs along the bottom that they've been part of those clinical trials. They've lots of different sorts of data, not only from the trials, but also from physicians, from imaging, from the participants themselves. Dr. Dorsey, you'll see his photograph shortly, he's just signed a contract with Apple where they've created an app for Parkinson's disease patients to monitor their progress every single day. So we talked, I think, at lunchtime about the velocity and the volume of data that's coming. So this is what they're going to do with this data. I've asked them, so, you're going to get all of this data, what are you going to do with it? The answer is, we're not sure yet. I have some ideas for them, but we'll get to that. But again, getting all of this data, the more data they can get to help them understand how these patients change over time. More about their drugs. These are all the different types of longitudinal data studies that they have. And at the end of the day, what we're really trying to do is to understand what is the shape of the graph? How does this patient's disease change over time? How and why does that progression change, is different between one patient and the next? Dr. Keeper shared with me that most important to him is he has a patient a woman who came in and he diagnosed her with Parkinson's disease. I think she had symptoms in her small finger, in her left hand. That's all. And she's had it for years. And the disease has not progressed. And he said, why? What is it about her that is so different than the next patient who came in and the disease progression was so steep? He says, I want to understand the two ends of that curve. Because if I can answer that, we're on to something. This chart talks about all the untapped data. That blue slice, this is all the data they've done nothing with. All of that information in there. My friends in the analytics group there, I'm sure you'd love your hands on this just as much as we did. All of that data, there's patterns in there that are surely useful to somebody. Their thought is to try now and to get to leverage this data using these types of studies. So can we identify patient-level factors which drive this change in the graph? You can see those little charts, just a little bit. These just to verify the change. Those graphs are not the same for every different patient. What are the factors that change? What are they? If I'm the lady with the Parkinson's that just demonstrates in one finger, what are the attributes for her that are so different for the other person? This is where our study was going to begin. So we got a recipe for success, at least we hoped so, as we started into this proof of concept type experiment we were doing. We partnered with the University of Rochester and our friends from IBM and put together this team along with the IBM software to try and see could we create any model out of a subset of this data that made any sense. So let's talk for one whole slide on what we used from a technology perspective. So IBM have a suite of products in the analytics space, and we chose one component. In my day, a few years back when I graduated, it was all about IBM SPSS statistics. Fantastic statistical tool. I did all my undergraduate classes, I used that tool. Modeler is a tool that's been developed more for the business enterprise. It's intended to allow folks from the business school, as well as folks from the engineering school, as well as folks from the nursing school to perform these types of analysis without having the PhD in anything. So it's designed with a front end to it to help people get involved with their data, which is a good thing. I'm not going to read all of that good stuff, but I will tell you the tool we had to persuade the young statistician on the team, Peggy, that this was a great thing. By the time we were finished with her, she agreed. This is a great tool. So if I come to the project approach, so how do we go about doing this? Here we were, 3 disparate groups, all with different backgrounds and different experiences. We used a methodology, which in our business, we use this methodology across the board for all of the analytic type work that we do. It's called the CRISP-DM process. It's cross-industry standard practice for data mining. And this is a process that we use, and it really is designed to help make sure that you're rigorous in your method and that you think through the problem and don't just run along and try and model something and hope you've got an answer that makes sense. That actually doesn't work in practice. So looking up here, it starts out with business understanding. In this case, we needed to understand what the neurologist was talking about. Data understanding, we've got data, what's it about? You know, it's a long time since I've seen clinical data, way back to my days at working for Glaxo Pharmaceuticals. Getting the data, doing something with it, modeling it, and then knowing whether the model results were useful or not. And how do you know that? So what I'm going to do is walk you through each step that we took and take you down a level. So this is going to appeal hopefully a little bit to our folks who might be interested in the analytic side of this. From the nursing perspective, these are data questions, so bear with me, and you'll think about the data the way the neurologist taught us to think about it. You know, I like to think about numbers, but he wanted me to think about the lady with the Parkinson's in her small finger. And he kept coming back to me, talk to me about my patients. So starting out with business understanding, we had to sit and meet with our subject matter experts, our colleagues from the university, as well as IBM. IBM have their own experts in this field, and it was wonderful to have them in the room with us. We formed a great team, and we had a lot of fun while we were doing it. It's always good to have a sense of humor. At least where I grew up, it's always good to have a sense of humor. Data understanding, I'll talk to you about the data that we had and the decisions we had to make, because we had some serious decisions to make that would clearly impact the results we were going to get. The preparation we had to do in the data, and for those of you in the analytics world here, this is where you spend your life, cleaning up data. I think 70% of our time is spending up getting the data into some sort of useful shape before you can actually build a model. The fun part becomes, of course, when you get to the modeling, and then you get to see, well, how did we do? So I'm going to take you through this. So here you see their eminent colleagues, Dr. Kiebert's here on the right, and Dr. Dorsey, two very different individuals. Dr. Kieberts is the head of the neurology department, and Dr. Dorsey is he's an MD, MBA, so he's got a different mix in him. He definitely has the science, but he's got a business side of him as well, which makes him brings a different perspective to the team. And he's the fellow that is working with Apple to get the data. So he's also, I heard us talking at lunchtime about telemedicine. He has set up a telemedicine group for these experts to be able to provide Parkinson's expertise to patients who are not necessarily living in Rochester. So, you know, I think Dr. Kieberts is probably the expert in the disease. Dr. Kieberts is leading forward in terms of the practicalities and the business side of things. It's a nice combination. On the board, you can see standard doctor writing. You're not supposed to be able to read it. We couldn't read it. Dr. Dorsey stood up at the board with his pen, and he got great ideas. And, you know, I spent a lot of time zooming that out so I could figure out what the heck he was talking about afterwards. But you know, this was a session that we did together to understand what are we talking about and what are we trying to do. I organized that scratchy piece into something a bit more organized, given my background, right? So you can see we started off with a set of inputs. We decided a set of outputs that we would like. So the first one was the most important one for our study, which is really talking about progression of the disease. But if we were able to get a bit further, and you know, you're always optimistic a project can happen in days, not weeks. We wanted to understand the complications of dopaminergic therapy. So that's the therapy that you give when a patient gets to the point that the dopamine neurons that are being killed off, or they need some support. So being able to look and understand that and model some of those aspects would have been interesting. Surgical treatment. A lot of these patients have serious adverse effects. They fall. And being able to understand when those things happen, can you predict them? Is there some way to know? Would have been very interesting. Future studies, but as we were thinking the whole picture, we came up with all of these things. Dr. Dorsey, my practical neurologist, he had two sides of there's a research side and a clinical side. Being able to, the research side clearly, you know, it's all about understanding this disease. But the prediction of medication, surgical needs, home care needs, you know, if the doctor was able to tell you when you're diagnosed as having Parkinson's disease, you know, you are one of these patients that looks like you're in the shape of the curves about 3 years out, you're going to need home help. You need to put plans in place, start thinking about that right now, so you're ready. Wouldn't that be really nice if somebody could at least prepare a patient and give them time? So that's the practical side of life here. Again, this was our business understanding step. The next step in that business understanding is to lay out ourselves some data mining goals. So we're now getting down to the gory details of the data. What factors help predict the disease progression? So, you know, we're asking the neurologists, help us understand from your perspective, what do you see, what do you think about when you see a patient? The therapy, when will a patient need the dopamine therapy? How do you know that? What are the things you're thinking about? Because that helps us do our job when we're looking at that data. On the non-motor side of things, these are all quality of life issues. So what's the correlation between this, what they call the Unified Parkinson's Disease Rating Score, or UPDRS for short, and a quality of life score? So quality of life is, can the patient put on their own clothes? Can they feed themselves? Is there some correlation between these scores? And if so, what does it mean? What does it mean from a time perspective? Adverse effects, is fact that a patient's falling over every week a sign of serious, they've changed the rate of their progression, is that a sign? They don't know the answers to these questions today. So that's the point. Using this clinical trial data, patients they're looking at week after week after week for clinical trials. Now let's look at them from this perspective. So from a data perspective, now they had a lot of data, and they had 4 particular data sets that they thought would be a good place for us to start. When we started to investigate that data, we found that, of course, nothing's easy. 2 of the data sets had a very similar structure. So if you think of your Excel spreadsheet, you know, they had roughly right the same number of columns, roughly right. And the column names were close to each other, they weren't exactly the same. But that's important because trying to make them be the same was much easier than the other 2, which were 50 times as wide and nowhere near as deep. So we had some issues there to figure out what was our strategy around the data. And we decided we were going to start it with the 2 that were very much the same, and we were going to normalize them to be the same. So now we said our data structure is going to look like this. And that's our standard. And everything else we're going to align it to that. And as it turned out, given our timeline, we just stuck with those 2 data sets. Turns out we had about 411 patients to work with. You know, we had a lot more when we started, but some of them got off the study. Some of them we didn't have data for. You know, you think you have a gold mine of data, and you turn out we ended up with 411. And I can't remember how many we thought we had to begin with, but we reduced it a good deal. So this is Peggy here. Peggy was our University of Rochester person who understood the data. Every single column she understood. She has a book, and she's always carrying those books around. But we had to get our arms around that data, and we needed to understand that, because if we were going to model it, we needed to understand it. So we spent a lot of time here. There was 470 variables. And I would say the nursing staff would probably say, I get that. There's lots of variables in what we do. It was shocking to us that there was that much data, but there you go. And as I said, Peggy, she was the ultimate source of knowledge. So this data was all over the place, lots of tables. We just took a very systematic approach. We took it one table at a time. We flattened it, which means we made it to be one row all the way across. And we kept adding table after table after table. So you think of your Excel spreadsheet, which we didn't use, by the way, it was a database. We broadened it and broadened it and broadened it until we had all the variables in there. So we wanted to end up with one record per patient because we wanted to build a model to be able to predict what is this rate of change of this disease in each patient. That's where we were going. So that gets us to this UPDRS score. This is a score that each patient, the physician will measure for each patient. There's 5 components to it. Things like your daily living. The patient actually measured it for themselves, as well as the physician. Their motor skills, their mental state, and there's a couple of other standard Parkinson scales in there. But it's a score that ranges from 0 to 128. And all of these, what we wanted to understand was this rate of change. I've said here the curve shows a downward trend post-treatment. So what happens is that UPDRS trends up for a while. At some point, the physician says, the neurologist says, time for the dopaminergic therapy, and then it'll decline. But it'll only decline for a while because all you're doing is treating the symptoms here. And you heard Dr. Keepert saying it would be really nice if we could actually get something to stop it. But eventually, it'll tee back up again. So these slopes, the slope of this UPDRS score, we created what we call slope bands. You know, it's one thing having a score of a rate of change of 4, and another one is 7.6, and another one's 12.8. Those are single points, so we grouped them and we called them bands. So we had a band. Everybody fell into some band or other, and we give them lovely labels. I remember the night we came up with these labels. So we had somebody had an improvement. It was if their score was less than 4. Now, score means the rate of change. And that's an important thing to remember. This is the rate of change of disease. If that score was less than 4, they were improving. Now, that's my little lady with her Parkinson's in one finger. That's it. There were very few of them. There were more than her, but there were very few. Those who were stable, we give them fell into a range, and then we had slow declines, moderate declines, rapid declines, and extreme declines. So you'll see on the right here, our distribution. We had some here in the improvement group, and we had some in the extreme decline, but those were really small samples. This proved to be a big problem because we weren't being able to model that. We didn't have enough coverage, and you'll see, for those on the analytics side, you'll see the struggles we had. We've got good data in the center here, but the tails were causing us some pain. So, given we had problems on the tails, and your normal, we've now classified into these 6 groups. The normal process would be to try and do a classification model and see could we get something useful. Well, that didn't turn out to be so good because we didn't have good data on the tails. So we developed and took a different approach, and we did a 2-step classification process. So we started off with, we took that target band and we said, all right, we're going to just break it into 2 groups, the improvement group and everybody else, right? And we modeled that group. And we ended up with a lovely little, this is the IBM modeler nugget, that little gold fellow. You see him all over the time. So we modeled what I would call the improvement group. We repeated that process for the stable group. So now we have a second model. So the stables against everybody else, we were able to predict whether a patient, which group they fell into. And we did that all the way down. So slow decline, moderate decline, rapid decline, and extreme decline. And you can see we've ended up with 6 separate classification models. So that was step one of our modeling process. Okay? All we've been able to do now, though, is be able to say whether a patient belonged to one of these groups or all the rest. So we needed to find a way then to bring it all back together again to say, because we really want to be able to, our end of our day, our goal was to be able to put a patient information in and say, which group do you belong to? Because if we could say that, that is the beginning of the conversation that Dr. Keepers wants to have with his patient the first day he's meeting with them. Before I go into step 2 of the process, I just want to highlight, and our analytic friends in the room will appreciate the problem. So look at my improvement group here. I had 34 patient records and 33 predictors, which means I'm spreading myself ridiculously thin. There's very little useful content in here. And, you know, we're first to best to say this is a problem. But as a phase 1, and keeping going our approach, our hope was we would apply for a grant with Michael J. Fox to allow us to use a whole boatload more of their data so we can get more data at the tails here. We've got the same side problem on the other side. And as I said, you know, this was a big problem. And I see all my analytic friends saying, yep, you got a problem there. At least we recognized it, right? Anyway, we kept going. So now we need...
Just to interrupt, at the time it was a hope, but the grant has been approved.
The grant has been... That was punchline for the end.
But it's exciting.
It is exciting. So anyway, now we have these 6 what I would call binary models, and we want to bring them back together again because our goal really is to predict, combine them all to model that UPDRS slope band, the whole thing, and bring them together. So we kept going with all of that, and then we had our, everybody should be cool to know that we did have our test and training sets, all the correct things. Yes?
Could you give me a little bit of detail first on what models you used on the left, and then how you went about combining them?
Well, we used, I have to remember what models we used. I think they were mostly C5 models, decision tree models. Yes. Maybe not, I'm not sure about the 2 at the tails, but the others were. On how we combined them, we used an ensemble method within the IBM software to help us ensemble the models together. So the way I looked at that is it reminded me of, you're all going to never forget this image that I'm about to put in your head, and I hope it doesn't spoil you forever. But I kind of look at it as the Tower of London. And if you've seen the Tower of London, it's got these big gates, which are a crisscross effect. And I kind of look at the binary models, we're going down here one way, and this combined classification models bring me in the other way, so I can get full coverage of my data. That's mentally how I was thinking about this. We have...
So you're basically using the scores
from all
6 models to make a prediction.
Prediction,
I got it.
correct. And there are issues with that because we had problems on our tails. But we weren't going to let that stop us. Our intention here was to do a proof of concept to see how well we did, even with very poor representation at the tail. So on the right, and this next chart does a better job. On this side, we look at our training and our test. So you could, this guy at the bottom is the stable one, this whatever color that is, orangey color. Orange stable is the dominant. That was way back to the beginning. That was where our dominant band was. That dominated in our training set when we looked at the results. We were able to see stable appearing everywhere. Although we did pretty well, we pushed it against our testing set. We did a bit better on the extreme decline, which was a surprise, and one I'm not sure I still understand. Yeah, well, maybe we're just lucky. I'm not sure. Improvement, we did dreadfully on. That's the small sample, issue 2. Some of these others, we still have some problems there, but we were encouraged with what we saw. And I think that's how we positioned it with anybody that wanted to know. This is encouraging, but it's not conclusive because we've not got the best of data, and we need more. That's what we told Michael J. Fox. When they reviewed it all, they agreed. And as Don told you, we've just won the grant. I think we'll start in October. We'll take an 8,000 sample set as opposed to 422. And it will be very interesting to see how this modeling approach, well, first of all, will we need the modeling approach that we thought we had to have here? And second of all, how do the results compare? A little bit more about what modeler will show you. This is going along the diagonal. Of course, perfectly along the diagonal, you like all of the numbers to be the full amount and nothing off center, because now we've had perfect match, although I'd worry about a perfect overfitting. But the results reflect the picture. The results were encouraging. I think that was the strongest words I was going to use. They're encouraging.
One other question. With the scores, how often are the scores updated for the patient?
So the patients in these trials were met with over a period of 2 years, I think. And they had a visit every 3 to 4 months, I believe. And they were measuring the same thing every 3 to 4 months. And not all of the patients finished the trials, because these were clinical trials. Think about they're testing a drug, patient dropped out, maybe patient got very ill, patient didn't like the effect of the drug, whatever. In terms of, we took the complete data set from a trial. The trials happened maybe 10 years ago. The trials of the data that we're working on, the data we're going to work on, I think, is more current data. And as I said, Dr. Dorsey's now collecting real-time data through the Apple app to try and do something similar here.
Yeah, because what I'm thinking is the time series nature of the data.
Exactly.
To begin to model
Right.
that and then map that against the prediction in the model.
Yeah, so one thing that's important to note here, we took the very first question. You remember, go back to my organized picture of the squiggly words on the screen that the doctor had put up. We were working on creating a model to predict that rate of change of curve on the first patient's visit. So the only data we worked on was that first patient's visit. But you're right, there's a wonderful opportunity for looking at the time series data and being able to now look at the effect of the therapy over time, or the effect of exercise or of diet over time. Great opportunity. I mean, I was quitting my job and going to become a research scientist at the university right there, because there's so much data and so much opportunity and so many questions that you could ask to follow on here. But so this was the tip of the iceberg. But again, the way the university looked at it, and for them, this was a different exercise, bringing in some different group from the outside. And what we brought was, we had no hang-ups about the data, right? We know diddly squat about this disease, at least we didn't at the beginning. But it allowed us to ask questions that nobody's ever asked them before. And that was very liberating, because when you come in to any business problem in the work that we do every day, what do we know about being a manufacturer? We don't. What do we know about being a neurologist? We don't. But you get to know how to ask the questions and the things that are important when it comes to building a model. And I think that combination of their expertise in the Parkinson's disease area and our expertise in the analytic area just was very revealing for both of us. As I said, Dr. Kieberts, every time we met with him, he had such a wonderful way to think about it, because he's concerned about his patients. I sit with my patient. This is the conversation I have. You can talk to me about your silly models all you like, but this is what I want to know, and I want to be able to have my conversation with my patient. It kept it real for us, because it's easy to get lost in a model. I'm sure all of you build models just love it, because it's fun. But at least that's where I go. It's fun. But it kept our feet on the ground to remember what we're trying to do. So the next steps for us were, we put together a proposal. We met with Michael J. Fox, and we put together a proposal of the next piece of work. We've got 8,000. The next trial is 8,000 data points. Woo! 422 versus 8,000. I can't wait. Took them. They're very interested in the study. They're also very interested in exposing the clinical trials to others. So they want that data available to others. So there was a quid pro quo for them with the university. And they also are applying for a grant with this Udall Center of Excellence in Parkinson's disease. And that may also yield some monies in the future. That grant is not, I think that's probably next year where that will come to fruition. So there may be more funding in there as well. So they're hot to trot, this team. I think they're a forward-thinking group, and I look forward to working with them and hope we can be part of these studies going forward. So with that, I think I've answered some questions, but I'm opening the floor to anybody who has any questions, and I'll do my best. Was it that straightforward? No.
So, how many variables did you end up with at the time when you plug in the table?
577.
And you use that for all of that for your scores?
No, we did some feature selection to get rid of those that were really adding no value to begin with. And I think if you go back to the table, so you can see we ended up with 33, 20, 10, 15, 17, and 35. So we cut it down as best we could.
Just to follow up on this question, how did you do that? Did you do some exploratory analysis first to cut some of the variables, or did you use some kind of stepping process or whatever?
So a couple of steps we took. First of all, we used the expertise of the folks in our partners. So, there was things that they said, don't worry about that, take all of that out. So we did some of that up front. Then we did our own exploratory analysis, good to help us understand the data. We did some correlations, some graphs, had to look to see how things were working together. And then we used there's a feature selection algorithm within the modeler tool we used to help highlight those predictors it thought was important. And then as we built the models, we tweaked the models to try and improve the performance without overdoing it. That's the art and the science of this job, I think. So we did kind of a 3-step process, and there was 2 of us doing it, myself and my colleague, and we both think very differently, and that was interesting as well. I have a pragmatic approach about how I go about doing this type of modeling. And he comes at it in a very different way. And I'm sure when you're doing homework together, you students, you find that you will approach a problem in a very different way. That's a good thing, I think. We learned a lot from each other, and that also helped us explore the data, maybe in ways that neither of us thought about it. So that data exploration phase is a long process. I did a lot of the data work myself, and it's a very long, slow process. Any other questions?
Yeah, I assume that some of these patients dropped out of the trial at one point or another. Is there any pattern to who dropped out, and did that skew your results?
There was no pattern that we studied, but you're absolutely correct. There were patients who dropped out. And once we'd figured out they were dropped out, we took them out. But there was a data mining goal that we had, which would be a future goal, that says we'd like to understand that a little bit better. Because remember, this group in the University of Rochester, they're a clinical trial group. They want to understand who stays in the trial, who drops out, why do they drop out, and can we predict, is this one going to stay or not? Because that helps a lot in designing the trial. But we didn't, to answer your question, we didn't study that, but we recognized that would be a very useful thing to study.
I'm a doctor, and I know that when patients get into a trial and it doesn't seem to be working, they drop out.
They're done, right? They're done with that.
Worse, or sometimes they get worse in the
Yeah.
trial.
Yes, and if they're on a trial, and there were some who were on a trial, unfortunately there were some who died while in the trial. So, you went through that data, and that was a bit hard to, here am I, a numbers person, and you're facing the reality of the world here. There were patients who didn't survive.
Yes, I'm David Schwartz. I'm
Oh, David, hello.
IBM guy here. And my background is in healthcare data mining, and this has been fascinating for me. And I'm wondering if the Michael J. Fox data is going to give you an opportunity to look at geospatial variables in addition to variables that you.
So the data is coming from the university, and I'm having to think, and we as a company think geospatially a lot. So if there were different sites and the variability of the sites. So, but from a geospatial perspective, I don't know that data is in any of the trial data that we looked at. But it is an interesting question. We presented this topic at the IBM conference last year, and somebody asked us the variability between sites. So trial sites and how do they vary? That wasn't something we concerned ourselves with either. I think we, as a variable, we decided that we're not going to try and be worried about that. But maybe, as we thought about that, we thought maybe we should go back and see, was there a variability between sites? And is that an interaction we ought to think about? But I didn't see geospatial data, but there could be. And there's an awful lot of data in there, David.
Very quick question. So you ended up with 400 and some patients.
Yep.
For the Michael J. Fox data, the 8,000. Where was this data collected? Where is it?
It's in the University of Rochester.
But how did they get it?
Clinical trials. So they may be signed up with, and I don't know the drug company, but let's just assume, let's say it's Merck. They do deal with Merck. They're going to conduct their clinical trial. They'll conduct the trial, the university, on behalf of Merck. Merck will fund them for that trial. Everybody's happy. The data belongs to Merck, but the university has access to the data. That's an example. There are 7 or 8 drugs up there in that list that have been that the university was part of the development of through a trial. So it resides in the university, and there are legal contracts. I mean, for me to look at that data, I had to be there on their servers to do it. I could not in any way copy it to move it. So there are a lot of rules, as you can imagine, around the data.
Did you notice any cluster? Demographic?
I did some initial clustering as part of my data exploration, and I couldn't get anything that jumped out to say, wow, not initially. And I stopped doing it because I was chunked for time, and we were definitely going in a direction. But I did think about the clustering, and I do think that's a study worth looking at when we get back in there again. There has to be some pattern there that might be of interest to the whole question as to which part of the curve do I fall on, which bucket do I fall into as a rate of progression of disease. So it's an interesting idea, and I will make sure we remember to do it, because it was my first approach to it, was to cluster. So I was on that track initially.
Are you hoping to have even a larger data set than the one that you're
Yes.
Proposing to do now? And how large?
So the next data is 8,000. Beyond that, so the university has, as you saw, there was lists of them there. I didn't spend time to go through them all. There are each of those studies are different parts in the life cycle, though. What we wanted was all the early ones, because we want to be able to take the patient who's walking in the door, right? So that's the first visit. All you have is, the blood work and whatever test the doctor's done. You think about what a doctor does to diagnose a disease for that first visit. That's all you have. You want to be able to use that data, and it would be really nice to be able to say which bucket you go into. So I would love to be able to say, take all of those early trials and take all of that data. I don't know how much data that is. And until I do the 8,000, I don't know whether we've enough or not, because do we really have 8,000, or do we have 479? When we actually clean it all up and we actually end up with something. Because we're going to lose some patients for whatever reason, whether they dropped out or they didn't complete the data properly. So I don't know the answer to your question, what's the ideal data size. I just thought we were lucky to have